little bit about Life with Cancer. We are an evidence-based program that provides education, support, wellness, and integrative therapies to enhance the quality of life for those affected by cancer and their loved ones. And while hopefully many of you know about our program, we always encourage you to check out our calendar, as we always have a lot of really fun and unique things coming up. So let's get started. Dr. Yacur, Melissa Yacur, is one of our breast medical oncologists at the Inova Schar Cancer Institute. She is a native of Northern Virginia and is happy to be back in the area, continuing her practice. After finishing medical school at Temple University, she completed her residency at Penn State Hershey Medical Center. She remained at Penn State for a year as chief resident before continuing on to a hematology oncology fellowship at the University of Virginia, from which she graduated in June 2022. She has a research focus in late phase clinical trials and is actively involved in bringing in and setting up trials at Inova. So with that, I'm going to turn it over to Dr. Yacur.
Thanks, Jenna, and thank you everyone for coming. Really excited to be a part of what Life with Cancer has to offer and to talk about HER2 positive breast cancer tonight. This is a huge topic, and so what I thought we'd do today is just go over some basics. We should have plenty of time for questions at the end, but if there's anything that you want me to go over again or that isn't clear as I'm going through, Jenna, please feel free to interrupt. And so we'll be talking about HER2 positive breast cancer and then a new classification called Her2 Low. Oops, there we go. No disclosures. So this is just a review of what we'll talk about today. So I'm going to touch on general breast cancer classification and how we actually decide that a tumor is HER2 positive. We'll go over some basic treatment principles of HER2 positive breast cancer across all stages. Then we'll talk about what HER2 low positive disease is, and then talk about some new stuff that's coming out that's really exciting for HER2 positive patients and HER2 low. So some basics. So I'm probably preaching to the choir here when I say that breast cancer is a very important issue for research because of how common breast cancer is. So this is from 2021. So even more recent data is probably higher numbers than this. But this shows that aside from non-melanoma skin cancers, breast cancer is the most common cancer among females. And so looking for new research, new ways to approach this is of utmost importance. So how do we diagnose this breast cancer and how do we work it up? So most of the time, these cancers are found on either a screening mammogram or on a self-exam. Patient notices a lump, brings it to their doctor's attention. The majority of breast cancer is found either in the breast or in the lymph nodes under the arm, so either locally or locally advanced. Once patients go for imaging, we'll typically do a biopsy, and once the breast cancer is diagnosed, that will spur a referral to a breast surgeon and often a medical oncologist like myself right away. Sometimes we do imaging to look at the whole body, aside from just the breast, but there's a wide range of when to do this, when not to do this, and that's very personal, or that's very case specific. And then you meet a whole team of people, not just surgery and medical oncology, but potentially radiation oncology and plastic surgery as well. So some treatment basics. So this goes for not just HER2 positive, but for all breast cancers. There's so many different factors that go into how this is treated. And that's why this talk, it would be way too long if we went over all of this, but generally treatment depends on the stage of the tumor, which is where is the tumor in your body. Particular patient characteristics like underlying medical history, patient preferences, medications that you're on. and then the receptor status, which we'll get to in a minute. So what a receptor is it's a protein on the outside of the breast cancer. And there's three main ones that we look for to classify breast cancer. So estrogen and progesterone, which are two hormones, and then HER2, which is the topic of today's conversation, which we're going to talk about in much more detail. So all of these factors are going to play a role throughout the entire course of treatment. So we'll talk a little bit more about receptors. So the three receptors, estrogen, progesterone, and HER2 are the three most common. So two of those, estrogen and progesterone, are hormones. So tumors that are positive for those are called hormone receptor positive breast cancer. And then HER2 is a separate. A HER2 positive tumor can be hormone negative or hormone positive. So this chart here is a breakdown of breast cancer cases in women by subtype. So you can see here in the black, far and away the most common kind of breast cancer is hormone receptor positive HER2 negative, which makes up about 2/3 of our breast cancers. And then when the tumor is negative for all three of those, we call it triple negative, which makes up about 10 to 15% of breast cancers. And then HER2 positive cancers make up the rest, which are about 15% of all breast cancers. So most of what we're going to talk about today will be relevant for those 15% of HER2 positive breast cancers. There's some other ways to classify breast cancer that you may hear about or see on pathology reports. So one of those is histology, which is where the tumor started. Did it start in the milk ducts? Did it start in the lobules of the breast? And then we also have ways to look at genetic expression that can help us figure out some subtypes. So one of the ways that we actually figure out the receptor status is by having your biopsy or the surgical specimen sent to pathology, and they actually take stains and look for expression in the tumor, which is a process called immunohistochemistry. So these are examples of estrogen staining. So you can see up at the top, high estrogen staining is brown. So this is, for example, if the tumor was 90 or 100% estrogen positive versus completely negative here on the bottom. So the HER2 receptor is a little bit different than estrogen and progesterone. So HER2 stands for human epidermal growth factor receptor. It's a whole host of, or it's a whole family of receptors that guide cell signaling and growth. And so when these receptors go awry, or we either have too many of them or they're mutated, it can lead to uncontrolled cell growth and cancer. So the two ways we decide or we figure out HER2 receptor status is either looking directly at expression, which is based on the stains by pathology, or we can actually look at gene amplification within the cells to say, is HER2 overexpressed or is the gene amplified, meaning there's too many copies of it. So this is a amateur diagram by myself to try to explain this in a slightly different way. So this would be a normal breast cancer cell, and there are, HER2 is expressed on a lot of different cells, normal breast tissue. So you can see there's a few of these on the cell surface, and that would be normal expression levels. And then in the DNA of the cell, there's a couple copies of the HER2 receptor gene, which is normal, which is used to make HER2 protein. So we could detect the number of HER2 receptor genes in the cell, and we could say, okay, there's a few, that's normal. There's a few receptors on the outside, that HER2 is normal. So you compare that to a HER2 positive breast cancer, where by staining, we can detect way too many of these receptors on the outside. Or we also can detect way too many gene copies in the tumor. So when we say that you're HER2 positive, it's by one of these two ways, either by the staining or by looking at genes. So this is a spectrum of HER2 positive breast cancers. A and C are from a HER2 positive database, and actually B and D are from patients of my own that I have taken care of here at Inova. So you can see the spectrum, and we, based on how strong the staining is, we give it a score of either 0 to 3. So something that has 0 expression is considered negative. Something that's 1 is also considered negative. 2+ depends on the copy number of the genes. So if the gene copy number is low, then that would also be considered negative. And it's only if you're 3+ that you're considered positive. So this is kind of the traditional way we define HER2 positive disease. Any questions on that, Jenna, that came in? I'll keep going.
Yep, keep going.
Okay. So the treatment, again, this is very nuanced and very personal for each case. So this is going to be pretty, I kept it fairly broad because the treatment completely depends on the stage of the tumor. But all of these treatment regimens will incorporate drugs that target HER2, which we'll talk about. Sometimes HER2 drugs get combined with chemotherapy. Treatment can be before or after surgery if surgery is part of your treatment plan. Side effects depend on the drug. There's a wide range of side effects because there are just so many HER2 drugs, which is a great problem to have. But one thing they all have in common is that, at least initially, we will monitor an ultrasound of your heart every 3 months, because a shared side effect of these drugs is that they can cause weakening of the heart muscle. So we always do ultrasounds every 3 months at least to start. And then in cases where patients have surgery, even if you've gotten chemotherapy, the HER2 drugs will be continued to complete an entire year of therapy. So I wanted to talk a little bit about these drugs and how they work. So Herceptin was the first drug that really targeted HER2 and really changed the landscape of how we treat HER2 positive disease. So Herceptin is an antibody that targets the HER2 receptor. So that's the HER2 receptor on the cell. And when the antibody binds, it does a couple things. The first is it signals to the immune system to gobble up the cancer cell and get rid of it. But it also shuts down the signaling inside of the cell and tells it to stop dividing. There's another drug called Perjeta that works similarly, but it targets a different location on the HER2. So we can use these drugs together. So the antibody itself is doing, or is the active part of the drug. One of the ways that HER2 positive breast cancer treatment has really advanced is that we are taking that Herceptin molecule and making it, I don't want to say better, but making it more advanced by attaching chemotherapy to it. So the first drug that really came out was something called Kadcyla, or also called TDM1, which takes that Herceptin backbone, but it adds chemotherapy bound to it. So this is really great because when these drugs are circulating in your blood, the chemo is not really active. It's only until the antibody binds to HER2, then the cell takes in that antibody and the drug attached to it, and that releases the chemo inside the cell. So this allowed a targeted therapy for HER2 positive disease. Now, HER2 is found on other cells other than breast, which is why we still get some side effects, but it can then spare cells that don't have any HER2 expression. And that way the medicine just goes right to where that HER2 is. So Kadcyla has a very specific chemotherapy attached to it. There's a third drug in HER2, which we're going to also talk about a little bit later, which has a different chemotherapy attached to it. So these, they're called antibody drug conjugates, are really an exploding area of research. And a lot of drugs, you know, as we go through them, are based off of this kind of backbone. So for stage 1 tumors, these are typically smaller. There's no lymph node, tend to be no lymph nodes involved. Patients will typically go to surgery first, and then you'll get chemotherapy and Herceptin by itself afterwards. Again, the entire therapy takes a year to complete. Stage 2 and 3, you typically do chemotherapy first. And this is one way that HER2 positive breast cancer is different from other kinds of breast cancer, in that, you know, as you get into some of the higher staging, the chemo comes first. This is important for a couple different reasons. First is it shrinks the tumor, which can make the surgery a little easier. It also allows us to do systemic chemo that targets everywhere in the body. So if there's any disease that has left the breast, it can be targeted early. But really the most important thing is this assessment of residual disease. So after you get all of your chemotherapy, you go to surgery and we get an actual assessment of what did that chemo do in this particular patient. If all of the cancer is gone, that's great. That's what we're hoping for. But if there's cancer still living in the breast after chemo, we have the ability to see that, and then we can actually change what we do after surgery to try to boost any disease that may have not, or may have been left behind after surgery. So that's really one of the most exciting things. So one of the ways that we treat this is with 4 drugs. So 2 HER2 targeted drugs, Herceptin and Perjeta, and 2 chemotherapy drugs, which can be given multiple different ways, either 6 doses for every 3 weeks or weekly for 18 weeks. And then Herceptin and Perjeta to complete a year. So again, after surgery, depending on the treatment effect or whether there's any residual disease, that'll dictate what happens after surgery. So this is what I talked about already for residual disease, but it's probably one of the most important concepts in HER2 positive. And this is one of the most active areas of research, in addition to just creating new drugs. So again, it's an assessment of if any cancer is left after chemotherapy. So if there's a complete response, that Herceptin and Perjeta will continue to complete the year. But if there's residual disease, we upgrade our therapy. The current standard of care is to use that Kadcyla drug or TDM1. But there's an ongoing clinical trial looking at a different drug. So that may be changing in the future. So that's a broad overview of kind of treatment of early stage HER2 positive breast cancer. But again, the topic is so huge, and we're going to get to some updates in the stage 4 setting at the end. So
one question that just came in back to the staining that someone just wanted to confirm is that the darker the stain would be the higher the number.
Yeah, so I'll scoot.
Thank you.
Back here. So here you can see where this brown is the positive stain. So a 3 is the strongest you can get compared to 0, which is none. So okay, so I have it right on the next slide instead of going all back. So before I get to updates in the stage 4 setting, I wanted to just break and talk a little bit about Her2 Low. because this is also very important currently in the stage 4 setting, but I think it's going to have implications in an earlier stage as well. So I know a lot of people may have come to this talk to hear about HER2 positive. So HER2 low is kind of a subset, but a lot of this won't apply if you're actually HER2 positive. So coming back to this picture, what we have found is that with these newer drugs, we can actually exploit the presence of HER2, even if it's not extremely overexpressed. So that's how this HER2 low kind of concept came to be. So if you have no HER2 low, you're still considered negative. If you have a lot of HER2, you're still considered positive. But these 1 and 2+, instead of being negative, these are now considered HER2 low. And again, that is because we can exploit having some HER2 on the breast cancer cell and use some of these drugs when before that we couldn't. So HER2 low, this is a similar chart. So again, 15% of our breast cancers are going to be true HER2 positive, 15% are going to be triple negative, and then the rest, about 50 to 60% are going to fall into this HER2 low. So what does this actually mean? So again, this is now a target for patients who weren't typically considered HER2 positive that we can potentially use HER2 drugs for. So currently, the only way we can target HER2 low is in the stage 4 setting. But I think eventually we'll be able to target this in stage 1 through 3. So this is a drug that is very important in stage 4 HER2 positive breast cancer. It's called Her2 is the brand name, or trastuzumab deruxtecan is the generic name. So I didn't have a slide on stage 4 disease because that is much more nuanced. I think there's not as much of a standard approach for that. And there are a lot of really great drugs for stage 4 breast cancer. And we can talk about that specifically if anybody has any questions. But this is one particular drug that we are currently using in stage 4 HER2 positive breast cancer that is really, really exciting. And we're now starting to use it for HER2 low. So this is a trial, Destiny Breast 04. These results came out almost exactly a year ago, where they took patients who had been treated with several other lines of therapy, and then they either gave them another line of therapy of chemo or this new drug in HER2. And what they found was that patients did way better after getting an HER2 compared to another chemotherapy. And so this is the trial that really showed the power of, and this was all in HER2 low patients. So this showed the power of using these drugs, even if HER2 wasn't extremely overexpressed. So why does this work? So why is HER2 low even a thing? So some of the earlier generation HER2 drugs like Herceptin, Perjeta, and Kadcyla or TDM1, all of these require HER2 at very high levels. So especially looking at Herceptin and Perjeta, they bind to the HER2 receptor. And so if that's not expressed significantly on the cell, they have nowhere to bind. They're not going to have a significant effect. Kadcyla also depends on having an overexpression of the receptor in order for the drug to get inside the cell and the chemotherapy to be released. But in HER2 is different. So when it comes to these antibody drugs that have chemo attached to them, if you look at over here, this is like Herceptin, where there's no drug, it's just the antibody. And HER2 is all the way over here. So for every single antibody of an HER2, there's 8 chemotherapy molecules attached to it. So that has, it's very potent, and it can deliver a huge amount of chemotherapy only to the cells that have HER2 expressed. So this is another way to look at it. So when the drug binds, it gets taken into the cell, and the chemo is cleaved off of it. The chemo's in the cell, it works to kill that cell. The other thing that's really special about HER2 is that the drugs can actually then diffuse out and kill cells surrounding it. So even if the cells around this one don't have that high level of HER2, they can still get active chemotherapy. So we think this is one of the reasons why Her2 Low is a target, especially with this particular drug, because of this that we call the bystander effect. So unlike the earlier generation of HER2 drugs that require every single targeted cell to have a high expression of HER2, within HER2, it can be variable, and you don't need that much. So that is a little in the weeds, but this is something we're really excited about. Just to look at kind of what's coming next. So, I had mentioned that, treatment of stage 4 HER2 positive breast cancer uses all of these drugs, and there's several others I didn't talk about. But one thing we're really excited about is trials looking at using HER2 first in the metastatic setting instead of some of the older generation drugs, because we think it's more potent. You can deliver more drug. Currently, HER2 is approved in later lines in stage 4. The other thing that we're looking at, and this is not in Her2 Low, but in HER2 positive, is what we do in the setting of residual disease. So right now, after chemotherapy up front, go to surgery, we use that Kadcyla drug, but there's an ongoing clinical trial comparing using Kadcyla to HER2. So we're really excited to see what that shows. And there's an emerging concept of something called Her2 ultra low, which is somewhere between 0 and 1 on that spectrum of HER2, where there's maybe a focus here and there that has higher levels of HER2, but that is still being figured out by the pathology world. That was a very broad overview, but these receptors are important markers. We use them to determine our treatments. And HER2 is the field is just exploding with research coming out in all stages and new drugs on the horizon. We look at receptor expression as well as the gene amplification to determine the HER2 status. And then this concept of Her2 Low is a promising target, which opens the door for more patients to use these HER2-directed drugs. So I sped through that, but if anybody has any questions, I think we have plenty of time.
We have lots of questions coming through the chat, so I will start kind of with those, and then we can have people unmute as we go.
Sure.
So again, if you can just go back over the staining. I think just an understanding of kind of the different staining, because I think someone was like, "Oh, 3+ is that the worst?" And it's really just explain, just kind of what that means.
Yeah. So the staining is literally the pathologist will take a slide that has the tumor on it, and they'll put what we call a stain, which is a molecule that binds to whatever they're looking for. So in this case, it would be HER2. And then the intensity that tissue stains is how we grade it. So if you look at 0, there's none of that brown. Whereas 1 has a little bit more, 2 has a little bit more than 1, and 3 has a lot. So pathology has a very specific way of how they determine, are you 0, 1, 2, or 3? And so there's not one of these numbers that's better than the other. It's just, what is this particular breast cancer? How do we classify it? And then that lets us know what treatments are likely to work. So traditionally, 3 is the only one that would be considered HER2 positive. Unless you're 2, but we do the gene amplification, and if that's high, then you'd also be HER2 positive.
And again, just a clarifying question, that the current sort of state is that staining 3 is HER2 positive, and anything less is then classified now as HER2 low.
So 0 is neither. That's just HER2 negative. And then 3 is HER2 positive. 1 is HER2 low. And then 2 is HER2 low if your gene expression is low. But if your gene expression is high, you would actually be HER2 positive. But yeah, the pathologist does all of that testing.
Wonderful, thank you. One other question that came in is positive, sort of determining where someone falls in terms of HER2 positivity. Is that determined only through biopsy, or is there any other way to determine that?
So as of right now, actually looking at tissue is the only way. My suspicion is that eventually we may be able to do it through blood, but that is nowhere near ready for prime time or actual use. So right now we actually have to biopsy. And another point to that is these receptors can change over time. So, for our stage 4 patients, if there's an area that starts growing after you've been on HER2 treatment, we typically will re-biopsy and recheck the receptor status, because all of these can change. Even the estrogen and progesterone, they can all change. For earlier stage patients, we typically don't recheck, during treatment. But if, heaven forbid, the breast cancer comes back, we'll recheck at that time, because the receptors can change.
Okay. So one question came up that, I think someone would just like to hear a little bit more about what comes after in HER2, that the sort of, I think, treatment thereafter, tucatinib and capecitabine are maybe not as effective. And so just some interest in what's potentially coming down the pike.
Yeah, so is this mostly in the stage 4 setting? Is that?
The person didn't say specifically.
Okay. So the drugs that you mentioned are mostly used in the stage 4 setting. So there's Herceptin, Perjeta, there's the Kadcyla, TDM1, and then in HER2. So those are our 3 main antibodies that we have right now.
Okay. And Dr. Yacur, it is stage 4. Yes.
Okay.
Yeah.
So then you mentioned tucatinib, which is a completely different class of drugs. So that's what's called a tyrosine kinase inhibitor, which also targets the HER2 protein. And in stage 4, it's typically combined with a chemotherapy, Xeloda. There are several of these tyrosine kinase inhibitors that can work. Those are interesting because some of them will cross the blood-brain barrier very well. So that gives protection to the brain as well. There are several other antibody drug conjugates that are in development. So similar to Kadcyla and Her2 that have other drugs attached. So I think that's really the way this field is going. So I anticipate that there will be more of those on the market coming up in the not too distant future. And of course, there's more traditional chemotherapy that's not HER2 targeted. And then if the tumor is also hormone receptor positive. There are ways to target hormone receptor in combination or without HER2 targeted therapy. So that opens several other arms of possible treatments. So, but really thinking about what's coming, I think the antibody drug conjugates is where there's the most active research. And our big, the annual breast cancer conference is in the fall. And so I expect some updates at that point. If that answered the question.
Great. Thank you. If you can go back to the slide where the Kadcyla is, there was a quick question about that slide. Is there another slide with the Kadcyla on it? So there was, I guess someone had a question about what column was Kadcyla.
Oh, this one?
Yeah, there we go. I think that's the one. And they were asking sort of what like the DAR again.
Okay, sorry.
Yeah. Thank you.
DAR is drug to antibody ratio. So the antibody is this structure here, and then they attach the drugs to it. So when you look at Herceptin, this is 0 because there's 0 drugs attached. So for every Herceptin antibody, that's all there is just Herceptin, compared to an HER2, which has a drug to antibody ratio of 8. So for every antibody, there's 8 drugs or 8 chemotherapy molecules attached. So this is, I consider, the most potent, because for every HER2 receptor that's open for in HER2 to bind, it can dump 8 chemotherapy molecules into that. So I'm going to go back to Kadcyla here, which you can see has 3 drugs attached to it. So it actually, there wasn't a column for it on that chart, but there's 3 chemotherapy agents there.
Okay. And I think just a sort of follow up to that. So if you can just kind of go back over what an antibody drug conjugate is and how that's different from the Herceptin and Perjeta combo.
Yeah, so Herceptin and Perjeta are the simplest of the HER2 drugs. They are just an antibody, and that's how they work. So if you see these pink molecules here on the cell, these are the HER2 receptors. And so when these are on a cancer cell, they are causing things to happen inside the cell that lead the cell to divide. So when Herceptin binds, it does a couple things. It actually attracts the immune system to come and eat the cell and kill it, but it also shuts off the receptor so that the signaling that's telling the cell to grow, that shuts down. So that's how Herceptin works. It either makes your immune system eat the cell or just shuts down the cell growth. Whereas an antibody drug conjugate, what that term means is that you have the antibody, which is Herceptin, and then conjugated to it or connected to it by protein is a chemotherapy drug. So that when the antibody actually binds, it delivers that chemotherapy into the cell. And then the chemotherapy acts inside to kill the cell by whatever mechanism the chemotherapy drug has. So Kadcyla and in HER2, they have different drugs attached to them, which is why they have different side effects. And they're kind of they can be used in different ways. So these antibody drug conjugates we're really excited about because they can deliver high amount of drug just to cells that have HER2 on them.
And you mentioned, Dr. Yacur, side effects. So somebody asked about, can you talk a little bit about the side effects of Her2 and Kadcyla, and are they a bit harder to tolerate in comparison to Herceptin and Perjeta?
Yeah, so I think the short answer is yes, they are, because they have those chemotherapies with them. So Herceptin and Perjeta alone are generally well tolerated. The biggest side effect is, well, the most serious side effect that we worry about is the effect on the heart. weakening of the heart muscle. So for any of these drugs, that's why you get an ultrasound every 3 months. But other than that, Perjeta can cause some diarrhea, especially the second week after you get it. But other than that, they typically have very few side effects. They don't affect your blood counts. They don't make you lose your hair. They don't typically don't cause a lot of fatigue. Whereas these antibody drug conjugates, because you're also getting chemotherapy, you do get some chemotherapy side effects. So that can be, effects on your blood counts, immunosuppression, anemia, GI side effects, nausea or diarrhea. We always will watch liver and kidney with these drugs. Kadcyla can cause some peripheral neuropathy, so numbness and tingling in your hands or feet. And Her2 has a very serious but rare side effect where it can actually cause inflammation of the lungs or pneumonitis. So that is something we watch very carefully for, but that's unique to Her2. So depending on what drug is attached to the antibody, that will determine the side effects. Kadcyla has a drug that is similar to Taxol or Taxotere, which some patients might recognize. So it causes similar side effects with the neuropathy. Generally speaking, I think patients do well on these drugs.